Thank you very much for an excellent presentation, and thanks to all four speakers for really very, very interesting discussions. And their experiences have been really quite eye-opening. Well, I think we'd like to kick off, and we'll go through the questions that have come up on the chat first. I think one of the things I'd like to just ask before we go into that is just this point of what is the correct amount of energy. Because as Professor Tang said, first of all, we recommended 40 watts back in 2019, but we've also found that when our machines went back for servicing, it was not sufficient. And when they came back, we repeated our porcine liver, and there seems to have been a modification that's been made, and certainly we're getting the same effect that we used to get at 40 watts. We now get at about 55 watts. I don't know if Dana wants to jump in at this point, but there does seem to have been a change in the actual setup of the machine.
Yeah, the power of the machine was, the initial one was adjusted according to the tumor ablation system. And then after, in 2020, we made the adjustment to the power setting, and the tumor ablation system and varicose veins ablation system, they started have a different power setting. That's why there was some confusion. But right now we have the specific corrected ablation protocol, and I'm sure we've already shared with many of our doctors. So if there's any more confusion, we can also answer that after the meeting.
I think that's a really important point, because I think that what's come across very clearly in this presentation is that this is, this is a very nice technique. And I think it's just important that we don't have bad results due to a simple change of that, and us for the new setup, might put people off what is a very useful technique. So I think it's very important to know that if you have the original machines of the tumor setup, 40 watts was without doubt effective, and we've got in vitro as well as clinical data. But if you've now had the updated settings, then you really need to be using probably 55 watts, and we're doing some work at the moment on porcine liver to find out exactly what that is. I think that's come across very clearly in the presentations, certainly from Professor Tang, and also Professor Borchek as well, that how that change has happened. Well, let's go through some of the questions that have been asked, and we'll just do these in order. The first one that was asked was when Professor Tang was talking, saying, Prof, if there are varicose veins down to the ankle, then from where should we puncture and insert the sheath?
That's a very good question. So where I puncture normally, it depends on what the degree of severity of varicose veins are. What are you treating it for? Are you treating it for symptomatic relief, or are you treating it for ulcer? So if you're just doing normal CEP2 disease, I normally go mid-calf or proximal calf, and I avulse the varicose veins as being a vascular surgeon. And I think the phlebectomies do a better job. What I haven't shown you in my data from Maestro was actually the outcome data, the quality of life scores at 1 year were worse actually with those who had phlebectomy, which was very interesting when you broke out the two cohorts. It's very interesting. I don't understand that why. My feeling was always, especially when you use non-thermal, non-tumescent techniques, that actually the phlebectomies were quite crucial, because if you look at all the data from the glue data, a lot of patients were coming back for re-interventions. So I tend to just for a CEP2, mid-calf, proximal calf, and avulse the veins. If it was an ulcer, I would go right down to the reflux and deal with the reflux. And I changed the catheter around now. I do a bidirectional approach. I puncture the proximal calf, head up, puncture down into the ulcer base. So I hope that answers your question.
That's very clear. Thank you very much. Also, then moving on, perhaps for our last speaker, Dr. Vertigej, can you just ask, what is the difference with the radio frequency of the Medtronic closure fast and the echo microwave system?
To my experience, the main difference starts with steerability. Closure fast, as you know, active tip of the probe is several centimeters long, and it's quite not flexible. In comparison, a microwave probe is very soft, so to speak, till to the tip, and the steerability is really, really better. The other gaining the experience, I dare to use, as I showed, to ablate also the a bit longer perforator with this long probe, microwave probe, with no problem, and also introducing the probe into the perforator was not a problem. Here it comes also into advantage that the active tip of the probe is shorter, a little more than 2 centimeters, and this is also, from my point of view, a relative advantage, because you can be more versatile using the technology.
Thank you very much. A very clear answer. I'm just, we've actually got a case share that we're actually going to show at the moment, which I think might stimulate a bit more information, a bit more discussion. And this is a case share, How I Did It, by Professor Khalid Abdulal. Thank you very much.
Yes, Professor Khalid could not join us due to poor connection, but he sent his recording, so I'm going to share it. Can you see it?
Good evening, everyone. My name is Khalid Abdulal. I'm consultant vascular surgeon in Mediclinic Al Ain Hospital, UAE. I apologize I cannot be with you today because I'm outside of the country. However, I want to share with you my experience with the EMA device for endovenous ablation and how do I do it. I wish first to express my gratitude to the ecosystem team to give me this such a wonderful opportunity to share my experience with such eminent participant. I hope you find my presentation useful, and by the end of the presentation, since I'm not present, you can send me any question on my personal mail. I'll be very happy to answer you. So the endovenous microwave ablation for lower limb varicose vein. How do I do it? First of all, before using any technique, you have to understand the technologies that lies behind, because when you understand better, you can expect results.
At the moment, we only have the sound.
You don't have the image, is that right?
We don't have any images at the moment, no.
Okay, how about now? Can you see it? Still no?
Not on my screen. It just says that you're sharing the screen.
Not on my screen also.
Okay, let me try one more time. Can you see it now?
It says you've started screen sharing, but there actually isn't any other thing at the moment. The vision hasn't come across, the presentation hasn't come across at the moment.
It's a video recording, but I don't know why it's failing.
No, it's blank at the moment.
Okay, sorry.
So, shall we do some questions while you have a look at that?
Yes, please.
Okay, that's fine. But we'll go through. I'll just run back this a little bit more. I think there's one here. If we can ask, I think it's Professor Kohler who was talking about some of the other techniques as well. And perhaps you'd like to answer his view of why don't we use 100% glue 0.1 mil for perforators? Is Professor Balaji Kohler there? No? Does Dr. Hang want to
yes,
answer
please.
that?
Yes, please.
Oh.
Can you please repeat me the question?
Oh, sorry. Yes. So the question was put by one of the people on the chat. Why don't we use 100% glue, 0.1% for perforators? So why don't we use glue for perforators?
See, the flow rate of the glue is not controllable. Like when you're treating these big varicose veins, you cannot control this glue unless you have a super glue, which is stable and which is the viscosity is different. So this viscosity is not, it's more of flowable, and it can go into the deep veins. So it is not possible to treat through that.
Thank you. Are any of the panelists using using the microwave to close perforators?
We do use sometimes, like if the perforators are big enough, like we are using microwave antenna.
And we've certainly used the trollop technique in this, the microwave straight down, and got very good results, provided you put it right at the fascia. I think it is a very nice technique for that. Is Dr. Hang with us here? Is Dr. Hang still with us?
Yeah.
Hello there. I just wanted to ask also, one of the questions was your targeted stripping. Is that at the same time as the foam sclerotherapy or different? How is that different from doing sort of foam and then phlebectomies? What's the actual targeted stripping?
Mark, I don't think he's here on. Oh, there he is. Okay.
Oh, okay. I'm sorry. I'm sorry. I was on the operation. Yeah.
Oh, that's very good.
Yeah. We will do the. We did do the target stripping at the same time when you after the microwave ablation. So what is the career?
So what's the difference between a targeted stripping and a phlebectomy, or is it more or less the same thing?
I'm sorry, the network is not quite clear. Maybe I walk away. I'm sorry, there's an emergency operation. Need me to do it.
That's what we'll try. If you can't hear, don't worry. The question was just: is the targeted stripping you spoke about after the microwave, is that different from phlebectomy, or is that just like a big phlebectomy?
Can you louder?
Show it.
Okay. Our room. Okay. And maybe in this room, maybe okay. Okay. This room is very silent.
Okay.
Your questions?
We'll try one more time. Just say your targeted stripping. Do you do that after the foam sclerotherapy, with the foam sclerotherapy, and what's the difference with targeted stripping and phlebectomy?
You mean the difference from between the point form stripping or the target stripping, right?
And
yes,
phlebectomy.
Okay. Yeah. Target stripping may make less insection. When we found a point which the reflex is very severe, very serious. Then we will make an injection to it to cut it, make a stripping. The PFS, that is point form stripping, maybe the marker is made before the operation, pre-operative market. Can you understand?
So it's
that
still the
difference between.
It's still the veins just under the skin, but you're taking out longer sections. Is that right?
Yes.
Thank you very much.
Small. I'm sorry.
Thank you.
The network is not quite good.
Professor Vitti, can I ask you a doubt?
Sorry?
Can I ask you a doubt?
Yes.
Yeah. So if we have a vein whose width is more than 8 mm, which increased to around maybe like 1 centimeter. So what is the difference if we increase the wattage and maintain the same time, or otherwise instead keep the wattage same and increase the time?
That's a really good question. I think that's the same with all thermal ablation. And with the work that we've done in the porcine liver model would always suggest keep the wattage the same and increase the time of dwell. I think the problem with increasing power, we have this strange idea that increases efficacy. All that happens is you get more charcoal, and then you get more problems, pain, and less conduction. It's better always to reduce the amount of power and to increase the time, and so you get the thermal spread. Professor Tang, what do you think? Do you agree?
Oh, I wouldn't disagree with you, Mark. No, can I just come back? Yes, no, I take that with a bit of jest. Sorry, no.
So
just to answer your question first of all, I'd like to go back to that targeted stripping because I think it brings up an important point. Can you hear me?
Yes.
I can hear you.
So first of all, replying to your question, definitely, I would not change the wattage. I have a very successful ablation rate using the 40 watts. And that's why I want to ask Dr. Varicose, actually ask him, why does he think, he's getting those kind of reopening? And what does he mean by reopenings? And how many re-interventions? That's my first bit. But just to go back to your question about using a same wattage and increase the time, you get less charring on the end of the tip. And I think that's very important because I think that's when you lose the efficacy of the tip itself. That's why keeping the wattage the same and actually dropping and increasing or decreasing the time is better. And that's what I do for surface veins. Let's just talk about that targeted vein stripping that I'm not sure people really understand. I didn't really understand, to be frankly honest, from the speaker, what he meant. But I think what he means is that when you've got a GSV, for example, that goes in and out through the epifascial layer and goes to the skin surface, my tendency now is to, if I'm obviously blocking a long distance, is to puncture low and re-puncture just above that vein on the surface, and I will strip that bit off because I think the risk of damage, even if you get good tumescence, is actually quite high. And actually leaving a cord that has been blocked can cause a pulling sensation that we know from the glue experience. And I think removing it gives you a better effect.
I must say, I totally agree with you. And we have a rule in our clinic that there's no thermal ablation that is on top of the fascia. So basically, if you look at the AC1, AC2, AC3 system, so AC1 being muscle, AC2 under the superficial fascia and AC3 outside of it, our rule is thermal ablation in the AC2 and then foam, phlebectomy, target stripping, etc. in the AC3. And you're totally right, if you've got a long straight bit that's become out that epifascial, your target stripping way better than and I do worry about people who say, don't treat a vein within 1 centimeter of the surface. I think the most important thing is it under the fascia? If it's under the fascia, it's safe. If it's not, you're probably not.
Absolutely agree with you.
Dr. Varicose, perhaps you can answer what we're talking about with the power.
Let me start at the rear end. At the beginning, I must agree about the skin injury. As maybe you noticed, we treated some veins which were not under the fascia, and all these patients had discoloration, pigmentation, hyperpigmentation of the skin. So I agree. Also with very precise tumescent anesthesia, the possibility of skin damage is quite high. So the next question was about the power.
Yes,
Yeah.
I mean, one of the questions Professor Tang was just asking about is, yeah, he was Professor Tang, do you want to actually ask that question again?
Sorry, I was unclear. Very nice talk, Dr. Varicose. I'm very interested about your results using the 40 watt 7-second protocol, because my results are very different in terms of closure rate. I just want to ask you, what did you mean by reopening of the vein? How did you define that? 5 centimeters contiguous segment, 10 centimeters contiguous segment? And were there any re-interventions or worsening of quality of life scores or revised VCSS score? How many of these did you have to re-intervene on? And why do you think you got such poor results using the 40 watt 7 seconds? Or would you blame the machine? which is easy to do.
I don't have the sound answer really. Probably we were thinking also in this direction that the setting of the machine was not quite proper. That is a possibility. Regarding what we treated as a reopening of the vein, yes, more than 10 centimeters open segment was the cutoff. And sorry,
did you have any re-interventions?
Okay, one second. I think we've managed to get online for the case, so we'll just have the case, and then we'll come back to this discussion because I think this is essential. This discussion. We now have the vision, but not the sound.
This is weird. Please continue the discussion. We will fix the problem.
Professor Whitley, when we have to puncture the GSV at the ankle level, do we decrease the time?
So that was going to be actually one of my questions I was going to ask the panel, actually, because I was going to say, just because you puncture the ankle, does that mean that you always heat the vein all the way down to the ankle? Or do you could stop at the knee? Just because you punctured the ankle doesn't mean to say you have to treat all the way to the puncture point. So I was going to ask the panel what their preference is. Say you did, the only access you could get was at the ankle, and the area of interest, and most of the reflux was, say, to the upper calf. Would you be happy to stop the heating at the upper calf and leave the bottom bit untreated, or would you prefer to treat all the way to the ankle if you've accessed it? Perhaps you could say, first of all, Professor Balaji-Kola, what would your preference be?
As we discussed, if we are treating the ulcer, then I would treat until 19 centimeters above the ankle. We generally puncture and we treat entire length. But if we are not interested in it, as you said, yes, we can stop in the mid calf level, and the rest of the part we can do sclerotherapy also.
Thank you. What about you, Dr. Tang? Yeah, it depends on the situation. So if it's ulcer, I'll treat all the way down. The other thing is I would be very careful with the tumescence. I actually reduce the power of the, I would reduce this is the only instance I would actually drop the potential wattage. But generally I would keep it at 40 and reduce the time. That's what I would do in that kind of area, if it's very close to the skin.
And Dr. Vertujets?
I agree with Professor Tang. When you are doing the ulcer case, I also go very low to the ankle. And I must say, I did with microwave 2 or 3 patients in such a way, and they had no unpleasant sensations after the procedure. I think, which is not the case when you are using in a similar way, let's say, laser. So I just did 2 or 3 patients in such a manner, but the result was okay, and the patients were not experiencing any neurological consequences.
But whilst we're just waiting for the last final glitches to come out before we hear the case report, I would just like to say that when we used to do a lot of, and we still do a lot of quality assurance on the porcine liver, and our original machine was showing fantastic results at 40 watts, 7 seconds. We then we had a machine that was modified with the new with the new setup. And actually, since 2020, we were getting very poor results, very much like Dr. Verchet said on that. And we actually we then took it back to porcine liver, and we actually found that if you have that setup, you don't get much power down the whole of the catheter. And I think, as you've heard, it changes with how much external to the machine. In other words, how much power is transmitted to the end of the device. And so I think you have to be very careful which setup
Good
you have
evening,
in your
everyone.
machine.
My
And
name
it
is
isn't a right or
Consultant
wrong. It's actually what is set, what you have right. And we're just about to move with our new setup that we have. We're going to have to move to 55 watts to get the same results.